Hello, good afternoon, everyone. Uh, First of all, welcome in the very important session of Indian Society of Critical Care Medicine. Especially, this session is specially meant for the nursing staff. We know that the nursing staff is very crucial as far as the critical care medicine is concerned, because they are the main backbone of the ICU. I'm sure that Anand is also agreed that if
Yes.
your nursing staff is very well trained, then most of your work can get done. And overall, by having a very good staff, very trained staff, at least that will definitely reduce the overall morbidity and mortality in ICU. So this is a very good initiative by Indian Society of Critical Care Medicine. And on behalf of ISCCM, I welcome Dr. Anand Joshi. Anand Joshi is a very well-renowned intensivist and is at present working in Australia, and he's a consultant intensivist affiliated with one of the major hospital in Hyderabad also. So I think without wasting time, Anand, let me start.
Yeah. Thank you, Raj, for those kind words, and welcome all the angels. As I would like to address all my nursing staff, you are the angels of the critical care and angels for all the patients. So this is a specially designed, structured training and education program by ISCCN, and I encourage all the nurses to regularly attend this because it's not that it's going to be a didactic one, but everything is given in the books. But what we would try to do is we would try to simplify the so much of knowledge into some tips and into some kind of small ideas where without an effort you are able to maintain it, remember it, and implement it in your day-to-day life so that you don't go home with the baggage after your shift. So today's topic is critical care bundles for the nurses. So I have named this as a new bundles in the critical care nursing. This is taken from the American Association of the Critical Care Nurse Pearls, implementing the ABCDE bundle at the bedside. Now, this is a very acronym. Everybody knows if we go by the acronym, then I think the life becomes much more easy. And for that reason, different bundles have been made. Now you know VAP bundle, Ventilated Associated Pneumonia bundle. You know CLAPC bundle, like catheter-related, catheter and line related to prevention of catheter-related bloodstream infection. Then we have COTI, that is again urinary catheter-related UTI. Neil, I think there is a echo coming up. So can you see that there are no two devices open at the side to side?
Sir, actually it is not my device, sir.
Okay, because this is echo coming up.
Hello?
Are you able to, are you getting echo, Raj?
Little bit, but otherwise it's audible.
It's audible? Okay,
yeah. From my side, no issue.
So yeah, so let's get on to this. So why this ABCDE bundle? So that is what I was trying to explain. So you have a COTI bundle, you have a VAP bundle. So this has revolutionized the approach and management. If you remember this bundle, then these are nothing but the steps of an evidence-based approach in managing a complex care of critical. Now, you know, when a patient is intubated, ventilated, having lots of say dialysis and everything, maintaining that kind of accuracy in your approach and maintaining the same step is very difficult. So what they have done is they have formulated various bundles, and you just have to say that, okay, this is the bundle. So everybody knows that what A, B, C, D, E, F, or 1, 2, 3, 4, 5, 6 you have to do. As a part of that, there is a new bundle which has been devised, which has been named as ABCD E bundle. Now let us see what is this ABCD E bundle is. Why another bundle? So again, this question will always come to most of you. We already are head up with filling up so many forms of bundles. Every day our nursing in charge comes and whether you have filled this bundle, that bundle. But remember, it is very important. Managing a critical ill patient is becoming more and more complex. It is no longer an easy affair. And for now, it's not that only one nurse is taking care 24/7. If that was the case, then it would have been still be easy, but it is practically not possible. There are different people taking care of a same patient at a different time of the day or the different time of different time of the day or different time of the week. Now, whether I take this care of this patient and you are an excellent one, but the other person is having some different approach. So for a same patient, this approach keeps changing. And when you don't have a consistency in your treatment, whichever treatment you make, then the outcome is not good. So for an effective care, there is requires an alignment of people, that all the nurses who are taking care should be on the same page. They should be following the same process, and they should also be following the same technology. It is not a question of how well or how good a one nurse is. It is very important how all the nurses who are taking care of the same patient are good, and not individually. They should be almost on the same page. So when we do a bundle approach provides a guide in the coordinated fashion based on the evidences, and this bundle brings a best care practice to the bedside. Am I clear on that? Right. So let us see what is an ABCD bundle. Something has come. Sorry. So ABCD is bundled is nothing but an evidence-based organizational approach. So what we have done is, there are some approaches to this critically ill intubated ventilated patient. Based on the different evidence, we have organized all these evidence step by step in a chronological order. With this bundle, the aim is to improve collaboration among all the clinical team members. Now remember, when you are talking about an ICU team, it is not only the doctors or junior doctor, it is also the nurse, bedside nurse, and the nursing in charge who is taking care of the patient. The third important aspect of this ABCD bundle is standardized care process. One nurse is extremely extraordinarily good, the other is a mediocre, and then whatever the good thing which have been done, the other nurse probably may not be able to, or suppose she is a fresher, you may not know it. Whatever the good thing you have done in the 6 hours will go down the drain in next 6 hours, right? So if you follow all the bundles for a very extraordinary nurse, you may find it to be a very what we call it as a very easy or a below standard, or somebody it may find it to be a higher standard. But then all of you are in the same page or the same standard of care process.
Anand, I'm sorry to interrupt you. There are some noise. There are some people are complaining that there is some echo, some noise
Sir,
is there.
do you have this thing, headset or something like that, where you can log in, you can join in?
Headset, huh? Just a second. I'll just be back. Give me a second.
So basically, I think.
No, sorry, I don't think I have. Someone is using two devices together. That's why there is an echo.
Okay. Okay.
Someone in the participant also, if they are using two devices, can you mute all? Mute
Sir, all the
except.
participants are muted.
Oh, is it?
Hmm.
Raj, can you mute yourself?
Yeah, I can.
Now can I hear? Am I audible now? Clearly?
Yes, sir.
Yeah. Now, okay. So I think it was from Raj. Raj, just give a thumbs up if you are able to hear me clearly without echo.
Okay, go ahead. I'll mute myself. Go ahead.
Yeah. Right. Okay. So now the whole concept of this ABCDE bundle is specifically designed for an intubated, sedated, paralyzed, ventilated patient. And by implementation of this bundle, you are going to make much major changes or try to prevent the major side effects which we get when we are sedating and paralyzing any critically ill patient on a ventilator. So what are these bundles? Why A, B, C, D, E? What does this stand for? A stands for A and B stands for awakening and breathing trial coordination. That is ABC. D stands for delirium assessment and management. And E stands for early exercise and progressive mobility. If you follow this bundle, then the chances of the patient coming out smoothly increases a lot. Now, I always give an example of Abhimanyu. Never be like an Abhimanyu. If people, those who know the story of it is much easier to go inside a Chakravyuh. It is like a Chakravyuh. It is very easy to intubate, ventilate, sedate, paralyze the patient and go to sleep. But it is much more difficult to bring the patient out. It takes a couple of minutes to hours to immediately intubate, ventilate. But it takes days for these patients to come out, which we call it as a weaning. And you know how difficult it is to wean when somebody is sedated and paralyzed for long. You always complain when you are trying to wake the patient, oh doctor, he is not properly breathing well, he's fighting, he's pulling out the lines, tubes. And that is what we are looking at as a delirium, and it becomes very difficult. So what do? You again sedate, again paralyze. And this cycle goes on and on, till he becomes so weak that he becomes difficult to extubate, and then you go on a tracheostomy, and then he's lying with a critical illness neuromyopathy because all his muscles are exhausted. So when you follow this ABCDE bundle, the chances that this patient go through these kind of problems drastically will come down. What are the benefit? What are the ABCDE bundle benefit? First, it will decrease the ventilator time. Everybody knows that the more the patient stays on the ventilator, the chances of the complication, including the ventilator associated pneumonia, increases drastically. It decreases the ICU length of stay. The more the patient stays in the ICU, the more there are chances that the hospital acquired infection, line related infection, not to forget the financial burden that goes up. Improved return of normal brain functioning. If you keep on sedating, paralyzing, if you keep on giving him midazolam, fentanyl, propofol, it's obvious that you are trying to control or suppress the brain activity. So dizziness, drowsiness, all these things while coming out as a withdrawal, you may not be able to achieve it. So if you try to follow this bundle, it will be much better and smooth transition of the patient from the complete comatose or anesthetized state to the normal function. It increases independent functional status. How does it increase? When you are trying to prevent the critical illness neuromyopathy, when you are starting the exercise early, when you're moving the patient early, when they come out of the ICU, their primary problem is done. They are not dependent. They don't have to go on the physiotherapy. They don't have to use the commode. They don't have to use the urinary catheter. The independent functional status reaches very fast. And obviously, when these things are coming out so nice, it improves the patient and family satisfaction. And of course, it increases the survival. It goes without any doubt that with patient and its family centered, nurses, physician, respiratory care, pharmacist, physical therapist, dietitian, and admin support, all of them are required for the better outcome. So let's take this one by one. We had seen the three components. The first component is awakening and breathing trial coordination, that is the ABC. So what is the problem which we are addressing by using this awakening and breathing trial coordination? The problem is of the prolonged ventilator. The negative outcome of the prolonged ventilations are ventilated associated pneumonia, immobility, delirium. Sedation is used to alleviate anxiety and agitation. But in return, what do you get? Either we over-sedate the patient, or he comes out to be so light that he undergoes under-sedation, and then he understands, recognizes, hears, and all those anxiety things will keep on in his mind. And not to forget the harmful outcome of being paralyzed, being affected. Suppose the evidence says that, suppose if you use a targeted sedation protocol, that means instead of empirically continuing fentanyl for 100 mic, 50 mic for hours and days, you target a goal. What is, how much should my patient be sedated? See, if you have a targeted sedation protocols, which I will show you later, you can effectively achieve the sedation goal. The goal of the sedation is that the patient should not fight with the ventilator, right? With the targeted sedation goal and using protocols, you can minimize the drug accumulation. You all know that these sedative drugs, they accumulate in the body. The moment you stop, it doesn't immediately come out. So that drug accumulation goes down and it maximizes the alertness. So it helps you to coordinate much better with your patient. Now, once these sedation protocols are in place, there is something called as spontaneous awakening trials, that is SAT you should give. The patient gets spontaneously awake, he is not in a distress, he is able to breathe spontaneously, it decreases the ventilator time and it decreases the complication without increasing psychological discomfort. This is closely followed by spontaneous breathing trial. So spontaneous awakening trial, he may not be breathing adequately. We have just decreased He's able to move slightly. He's able to open his eyes adequately on your command, but he's still on the control mode of ventilation. Once you shift him to the spontaneous breathing trial, you can adequately, remember, this is a breathing trial you are giving by changing the mode of the ventilator to either pressure support or a CPAP. You are objectively screening him whether he has enough muscle strength, whether he is breathing adequately, whether he is breathing comfortably or not. And when you are doing that, you are obviously decreasing the time on a ventilator, decreasing the complication. So once you have a patient with any disease, ARDS or whatever reason he is intubated, ventilated, and you feel that it's been 3-4 days, changing over your thought process of making a sedation protocol, give him daily spontaneous awakening trials, and trying to make him breathe spontaneously is going to alleviate maximum complications that can arise because of the deep sedation, paralysis, and control mode of ventilation. So this ABC protocol includes the synergy of spontaneous awakening trial and spontaneous breathing trial. This will decrease the medication accumulation, decrease the oversedation, and increases the opportunity of effective independent breathing. So in a common term, if you don't want to remember this complex awakening and breathing coordination protocol, you can just say, I want my patient to wake up and breathe. Wake up and breathe protocol. That's it. What does it include? Nothing but spontaneous awakening trial and spontaneous breathing trial. And it is a 2-step process. Before you try to wake up and breathe, you want your patient to wake up and breathe, first you have to see whether it is safe to do that. So there is a safety screen that you need to do. And the second one is the trial period, how long you need to give this trial. So now we are going to see how we are going to implement this ABC protocol by combining spontaneous awakening trial and spontaneous breathing trial. In common word, how you are going to practically ask your patient, wake up and breathe by 2 processes. Step 1, first safety screening. 2, have a trial period, determine the trial period. So what is a spontaneous awakening trial safety screen? So there are 2 components as we saw. One is a spontaneous awakening trial and another is a spontaneous breathing trial. So for, yeah, Mahesh, you raised hand. Mahesh has raised hand. Any question?
So at times it is just by
I think
default day.
we'll take questions afterward. Just message your questions in the chat box.
Yeah. So for a safety screen of spontaneous awakening trial, you have to see that the patient is not having active seizures. There is no alcohol withdrawal. He is not agitated and thrashing around. Most important, you are trying the patient to wake up, open his eyes. So there is no paralytic on there. You will suddenly see rocuronium is going on, atracurium is going on, and the patient is not waking up. How is he going to wake up? You have just stopped the fentanyl, but you have not stopped the paralysis, right? So see that there is no paralysis. Second, there is no load on the heart. There is no active myocardial ischemia going. Because when you are trying to awake a patient on the ventilator, he is going to try and breathe by himself. And when this transition is going from the control mode to the spontaneous mode, there is some amount of myocardial pressure is going to come. So if the patient is already having a myocardial ischemia, he is going to have a trouble, or he may go in full-blown MI. And of course, he has a normal intracranial pressure. Always remember, the spontaneous awakening trial and spontaneous breathing trial, these both of them are very, very, very closely associated. In practical bedside, you cannot differentiate. Just for our convenience, we are trying to differentiate between the two. So once you have screened the patient for spontaneous awakening trial, same breath you try to see whether he is safe for spontaneous breathing trial. That is, he is not agitated, his oxygen saturation is good, more than 88%, with FiO2 of less than 50%. His PEEP is less than 7.5. Never try to wake or ask the patient to breathe on a very high PEEP. What is going to happen in high PEEP? You are already asking the patient to breathe high and try to do that, because that is the high and expiratory pressure. You have to try to bring down the PEEP and then give spontaneous breathing trial. And of course, no myocardial ischemia is going on, and there is no vasopressor in use, and he has started having some inspiratory effort. If there are no inspiratory, the patient is awake, but he is not taking any inspiratory effort, it will be very dangerous for you to shift him to the spontaneous mode, because the ventilator is not going to give any breath unless he breathes. And if he doesn't have any breath, then it's going to be a problem. Always remember one more thing in the inspiratory effort. Always check for the trigger sensitivity. Sometimes the trigger sensitivity is kept at very large, say 6 liters, 7 liters, somebody must have kept. Or if it's a pressure trigger, then it is kept at some 6, 7, 8 of pressure, minus 6, 7, 8 of pressure, which is very horrible. The patient will not be able to breathe at. So you have to keep the flow trigger somewhere between 3 to 4 and the pressure trigger somewhere upon 2 to 3 millimeters of mercury. So this is the safety screening for spontaneous awakening trial and spontaneous breathing trial. Now, every 24 hours, if you see the chart on the right side or the left side, every 24 hours, you have to have a safe spontaneous awakening trial safety screen. If it fails, then do not proceed to spontaneous breathing trial. You have to, the patient has to pass that spontaneous awakening trial after the safety screening. Now, if the patient is not waking up, it's no point in putting him on the spontaneous breathing trial. If the patient wakes up, then only you can take him to the spontaneous breathing trial. If the patient does not wake up, that means your sedation is very, very, very large on board. The accumulation has gone very high. So you have to give him some more time for the body to wash out the sedation. So in that case, probably you have over sedated the patient. So you have to half the dose of the sedation, and you need to keep continuing till he passes spontaneous awakening trial. Once he passes spontaneous awakening trial, then you go to the spontaneous breathing trial, which again, he should not have agitation. He must be spontaneously having inspiratory effort and starts adequately breathing. If he fails that, then he continues to be on the full ventilatory support. And if he passes that, then you look forward that, okay, this man, a person is achieving or moving towards a extubation. So you don't immediately remove the tube. You just inform the doctor he is performing good spontaneous awakening trial and is comfortably breathing spontaneously. That's where you stop. The rest of the thing will be taken over by the doctor. Now, always remember awakening trial failure. When do they fail? What do you mean by that? So he's awake, he wakes up with a bang. He's anxious, he's agitated, he's in the pain, he's trying to pull the things, his saturation starts dropping, his respiratory rate goes about 30, 35, his heart rate shoots up to 140, 150. Stop that thing, resedate him, and do not give him the spontaneous awakening trial for that day. He is awake, but then when you try to make him spontaneously breathe, he becomes tachypneic, he becomes bradypneic. His oxygenation falls, he's in a respiratory distress, he starts getting agitated, he gets altered sensorium, delirium, or his heart rate starts shooting, going all over the place. That means he has failed the spontaneous breathing trial. And then you go back to your full ventilatory support, and with the half sedation or sedation, you keep on doing this cycle again and again till you get a decent response from the patient. The coordination and the collaboration is very, very, very important in this. Even though I have made this separate one, spontaneous awakening trial and spontaneous breathing trial, but it is a part of closely knit consecutive steps. And for that, we need to have not only the nurses, but the respiratory therapist, if you have the junior doctor and the senior consultant and the nurse, all of these people should be collaborating for these trials which needs to be going on. Now, every time you have if the nurse is performing, you have to communicate with the respiratory therapist or communicate with the doctor that I have given a spontaneous awakening trial, he has passed or he has failed. You have to tell them. He had passed the safety screen. I have given him a spontaneous awakening trial. He is comfortable. He has also passed the spontaneous breathing safety screen. I think he is a good candidate for spontaneous breathing trial. And with that, I am with everybody's consensus or community. Because for example, you may give a try, but then the consultant comes in and then he knows something else, that okay, this guy has got a big bleed in his brain and he cannot be done, or his ICP is very high and he should not be given. So you will know that okay, you know, your doctor knows something which you don't know, or some test investigations have come to him which you don't know. So communication in these aspects are very, very important. Whether you communicate with your respiratory therapist or consultant, it is very important that all of you are on the same page. Or during the morning rounds, you can ask, doctor, can we give this patient spontaneous awakening trial and spontaneous breathing trial? I would like to give it because I have been taking care of this patient for last 2-3 days. And if his primary problem is settled out, can we give from the nursing perspective? So this communication is very important, and this coordination and collaboration with the respiratory therapist and the junior doctor is very, very essential for successful outcome. Now, you have given done ABC, awakening, breathing trial and collaboration. You have done, everything seems to be good, but then the patient starts getting agitated every time you try to bring him out, and every time you fail. He's able to breathe, his heart rate is not going anywhere, his blood pressure is okay, there is no myocardial infarction, but whenever he gets up, he is delirious, he is agitated, he is kicking and pushing. So what, and you get stuck there. So what is this? This is a delirium, and how you assess and manage, this is what we are going to see now. The problem of the delirium is that almost 60 to 80% of the mechanically ventilated patient gets this problem. Usually because of the delirium, the intubation ventilation time is prolonged and it is a very costly affair. It is also independent factor which increases the length of stay, ventilator time, of course, the mortality and long-term neuropsychological deficit. Most of the time, it remains undetected and untreated in many patients because we are not focusing on that. Every time we say, oh, he just failed the spontaneous trial. Oh, he just failed the awakening trial. Why? His saturation fell down. His saturation fell down and he was having tachycardia. Remember, falling of the saturation in coordination with the ventilator, falling of the tachycardia, may be because of the anxiety or the delirium which he's having. It may not be a part of the primary problem. So many a times this delirium gets undetected and untreated. Delirium is defined as acute change in the consciousness which is accompanied by inattention and in either a change in the cognition of a perceptual disturbance. You need not remember all these words, but it just says that it's not a normal response of a patient or a calm response. You will find as a 3 types. Hyperactive delirium. That means you are trying to wake up the patient and the patient becomes restless, agitated, attempt to remove catheter, emotionally labile. Or he is in a hypoactive. You think everything is doing fine, but if you ask him to breathe, then only he breathes. Otherwise, he doesn't breathe. So this is also a kind of delirium. This is called as hypoactive delirium. He will be flat. He will be in a withdrawal. He doesn't want to breathe. That's all. You are seeing that he's awake. He's opening his eyes. If you ask him to lift his hand, he is lifting his hand. But when you try to put him on a spontaneous mode, he will not breathe. So this can be an hypoactive delirium. And of course, the next one is the combination of hypo or hyperactive. How do you manage this on an evidence-based factors? So assess the presence of delirium. Now, you need to find out the pre-existing risk factors. Whether this patient has Alzheimer's from before, whether this patient had a dementia from before, whether he had some mild dementia before, whether he had previous hypertension, whether he was alcoholic, whether he was, when he came, he had a stroke or he was very sick, he's been hypotensive for long. All these factors will determine the amount of brain damage which the patient had from the before. After this, you need an objective assessment, which we call it as a tool. So there are 2 valid and reliable tools, or there are different kinds of, there are many tools available on the internet, and many a times each unit will have its own protocol or its own assessment method. I will just be talking about some 2 famous or validated tools for the assessment of delirium. This is called as CAM-ICU score or ICDSC score. That is a confusion assessment method or intensive care delirium screening checklist. In CAM-ICU, the first step is you look for acute change or fluctuating course of mental status. So you have decreased the sedation or almost stopped the sedation. There is no paralysis going on. And you know that his baseline was say dementia, or that the baseline was normal. Is this an acute change from the mental status baseline? So they may say that the family may say, oh yes doctor, he was like this from before only. So before he coming normally also he becomes agitated. So that means you know that this is the baseline mental status he has got. Now you may see or get a handover that, in the morning this patient was very, very aggressive. And then when you go, you see, the patient is not at all aggressive. Then the next day when you gave the nurse the same handover, he said, Oh, the whole night he was very good. So there is a acute change in the fluctuation course of mental stresses. If this is not there, then probably you are not dealing with any delirium and you can go ahead with your other protocols. Suppose this agitation or the mental fluctuation is there, you just look whether he is having any coherence or orientation or attention or not. You can ask the patient some questions. You may ask, this is just a example which it's written here, squeeze my hand when I say letter A. So basically you are trying to give him a command, or if you are if the person is illiterate, you may use some pictures, and if the patient is able to follow your orders in say 5 to 10 times you have asked him the same question, and if the patient is having some errors, then probably this error is less than 2, then there is no delirium. But if it's more than 2, then there is a problem with his attention. So acute change, fluctuating mental course, you have checked, then you're looking for an inattention. So if the patient is inattentive, then you look for the conscious level. So there is a RAS scoring system. It's a Ramsey assessment sedation scoring system levels, which is quite widely popular, and look for the level of consciousness. If it's 0, then probably there is more than the delirium, the patient is too much of sedated, or there is really wrong organic problem with his brain. If the RAS is other than 0, then yes, you are looking at a delirium which needs to be addressed or treated. Now, if the patient is awake, his RAS code is 0, then you try to look for the orientation or organized thinking, and you go with the series of questions will change based on your local condition, local thinking, local language, local culture. But you ask some 3 to 4 questions, or you give the command and ask them to demonstrate. If they are able to do it without an error, then there is no delirium, but there is an organic issue going on. If there are more than one error, then you're looking at a delirium patient. So when you reach from A, B, C to D and you're assessing the delirium, you have to stop, think for yourself, and maybe, probably use some different medication. So when you stop and think, what do? You do any medications need to be stopped or lowered. For example, you suddenly realize that there were 2 sedation going on, fentanyl and benzodiazepine. And the question was, did you stop the fentanyl? Yes, you have stopped the fentanyl, but you forgot about the benzodiazepine. And you are trying to do a CAM ICU score, and that's why you are not getting any result. So look at the medication, whether you have stopped or decreased or lowered. Then just think, is this patient on a minimal amount of sedation necessary? The ideally is to not decrease the sedation, but to completely stop it. Do any titration strategies are needed, whether this patient actually needs complete sedation or whether he needs a low level of sedation? Or does the sedative drug need to be changed? For example, short-acting drug. I will stop, say, benzodiazepine and fentanyl, which might have accumulated over last 15 days. I will stop that and change it to propofol and then start thinking. So you have to stop any of the medications which are ongoing or long-acting, which will be accumulating. Then think, are there any other things which are interfering with the brain activity? Whether he's in a toxic situation like congestive heart failure, shock, dehydration, whether there are any other medications which are going on. Say the most common, I would say, is a lasuride. Now everybody gives a lasuride for as a gastric motility, but they forget that lasuride has quite a delirious effect on the brain. The patient is on lasuride for long, and when you try to decrease the sedation, the patient becomes delirious, and you think why he is becoming like this. So it might be a deliriogenic medications, or whether he is developing any new organ failure. Also try to see whether he is hypoxic, whether there is an infection sepsis going on, whether there has been a prolonged immobilization that is making him more delirious. Other non-pharmacological things, like for example, the patient wears thick glasses, and when he is intubated and he cannot say that he cannot see the things, and you are trying to make him understand and make him see, and he cannot see it. Or he is hard of hearing, which is a very, very, very common thing to occur. Sir, patient is not responding. Patient is not responding. And then you try to come and beat him. When you try to beat him, he will look at you. But when you're trying to shout and yell at him, even in his ears, he's not responding. Then you will suddenly realize that his family members will come and say, oh, he wears a hearing aid, and that's why he's not able to hear you. It's not that he's not responding to you, he cannot hear, that's why he's not responding. Third thing, whenever you talk to the patient, remember they come in a very sick state. So they may not be knowing that they have recovered and they are in a hospital. So you will have to tell them that, okay, you are in a hospital, you are in this hospital, you are in intensive care, you are in this and this ward, and then you had this problem and you are waking up. So try to orient them. They may or may not have slept for long. The sleep-wake cycle doesn't necessarily get all the toss when you are in a sedation. And when you wake them up, probably there is too much of noise surrounding it. So they get scared. So all these things are the non-pharmacological intervention which you have to think. Think is a mnemonic, T-H-I-N-K, K for the potassium and the electrolyte problem. So stop all the other sedation which might be accumulated. Think about all the differential diagnosis and probably medicate. If all these things are still troubling you, sometimes a small dose of haloperidol or any other antipsychotic like quetiapine may help in getting the things right. Last but not the least, early exercise and progressive mobility. So it is very important, once you have done a spontaneous awakening, spontaneous breathing, you have fixed all his delirium, there is still a bit of time to extubate, or you have immediately extubated, but the patient is still just extubated and he is still going back to the drowsy state or accumulating his secretions because he is very weak. To circumvent that, early exercise and progressive mobility is very important. So how early is early? ICU acquired, before that, just let's address why you need to do the exercise. One is ICU acquired weakness is becoming a very horrible situation. People are dying even after coming out, successful implementation coming out from the primary problem. And as a nurse or a healthcare professional, we also feel bad. We did so much of hard work. We did so much of thinking process. We gave all the heart and brain for this patient. He came out and then he died because he was so weak and he couldn't breathe. So ICU acquired weakness poses a big problem. It impairs the ventilatory weaning and functioning. So if you are weak, it's obvious that you cannot wean the patient. Unnecessarily tracheostomy comes up. Then the whole circle of ventilated associated pneumonia, hospital-acquired weakness, hospital-acquired pneumonia, all these things start. And this increases the mortality or even if the patient goes home for months together, they remain persistently weak. Approaching this evidence base requires an early mobility protocol. Always try to have an early exercise and progressive mobility protocol. Right from passive to active range of the motions. Even the patient is in the bed, even the patient is on a ventilator, unless he is very hemodynamically unstable, try to start doing the physical exercise passively. Try to move his hand, try to move his leg, and try to keep him in a sitting position as much as possible. If it's possible, try to make the head end up to almost near 90 degree. Try to dangle the leg in a chair fashion. If possible, try to make them stand. Now we are getting the in hospital tilt table. So many a times you can still make these patients stand. Suppose they are tracheostomized, then you can still make an attempt to make them stand with a tilt table. Try to ambulate them as much as possible. Try to make them sit in the chair. If they are on the thermovent or even if they are on the small BiPAP, there is no reason why they cannot be ambulated on the chair. So which we, in our ICU, at least we follow the things. Early ambulation will help the anti-gravity muscle to activate. Now, these are the mobility protocols that you need to follow. But before that, again, you need to see for the safety screening. So what is the safety screening? Again, patient must meet all these criteria. This is an example or simple sample I'm giving. So first look at the safety screening. Again, MOVE is the mnemonic. Move. M, myocardial stability. There is no active ischemia going on. There is no dysarrhythmia going on. Oxygenation is good. FiO2 is good. PP is less. There is no vasopressor requirement, or vasopressor is very minimal, NORAD of 1, NORAD of 2. Even for NORAD of 1, 2, don't stop yourself from the mobility. You should continue the mobility because that is all the things are parallelly going on. Who knows, when you start the mobility, the tone of your muscles increases and then your vasopressor requirement will go away. E for engages to voice. The patient is awake, oriented, but he's still requiring a small dose of vasopressor. That's all right. At least he's awake and he is able to respond to the verbal command. So once this safety screening is met, you go slow and steady. Level 1, level 2, level 3, level 4. So at least do passive range of movements of all the limbs at least 3 times a day. Second hourly turning. Active resistance to physiotherapy. Tell the patient, try to resist your hands, resist your leg. Try to put him in a sitting position at least for 20 minutes, 3 times a day. This, if he is able to move the arm against the gravity, that will be a fantastic. Then go to the level 2, become bit more aggressive. Then level 3, get more aggressive. And then you reach to a level 4 where you are trying to almost ambulate the patient, trying to sit him in a proper chair, or you are trying to use a bed pedals for him to pedal in the bed only, or you are asking him to stand at the place. So this is an example of progressive mobility. You can choose your way to do it, but important is move. Make them move passively or actively. So in this way, if you try to get all these bundles together, definitely this is going to help you in improved patient outcome. So again, recapturing everything: awakening, breathing, trial coordination, choice of sedation, daily delirium monitoring, early exercise and mobility, that is A, B, C, D, E, is going to improve the patient outcome. And this is what is all A, B, C, D about. I'll stop screening.
Thank you very much, Anand. I think it is very lucid, and you have narrated in a very simplified way. So I think now the session is open for the questions.
Yeah, I will see how I'm not able to stop this screen, share screen. Yeah. There you go. Yeah.
Okay, any questions?
You need to ask the questions, guys.
See, this is a very important things. Whenever you are doing a safety check, even in ICU, being a critical care nurse, it is very important to ask questions. Don't assume. So whenever you are doing safety check, whether it is for the wake up and breathe safety check, whether delirium safety check, whenever you have doubts, you have to ask the questions to your doctors. So make a habit over here also. Yes, I think there is a question. The sedation is related to delirium.
Yeah, I think it might be a part of the delirium also, because, for example, if you have decreased the, say, if you decrease the fentanyl, or if you decrease the midazolam or propofol, but you have not completely stopped, or there is a low level of paralysis going on, and there is a complete locked in state, and he becomes obviously agitated. So he knows, he understands, but you are not able to, he's not able to move. So he becomes agitated. So that becomes a part of, you may think that it is a part of a delirium. So stepwise, if you see that I'm going to circulate the PDF of the slides, if you go as a checkpoint, the first thing you have to ensure that the sedation is completely off. That is what the spontaneous awakening trial is, what you need to make sure of it. No paralysis is there. So that can help you in determining whether the patient is delirious because of something else, or it is because of your drugs going on.
Another question, how we can, what pharmaceutical treatment you give for hyperactive delirium?
Yes, that's a very good question. So first you need to find out, first you need to define the hyperactive delirium. He is getting agitated, he is getting he's getting aggressive and he's trying to hit you. First, try to have an eye contact with him. Try to see whether he is understanding what you're saying or not. There might be some syringe that might have forgotten when he was turning to the side under his bum, and that is poking him, and you don't even realize that this is there with him, and the poor fellow is every time trying to tell you something. So see whether it's a delirium, or he is trying to tell you something, or he is just not disoriented. Because when he had when he had, say, last he remembers was he was sleeping in his room, and then suddenly he is in an ICU where he is tied up, he cannot speak, and then different people are coming and beating him and say, "Kaka, aankhein kholo, uncle, aankhein kholiye." And these are the foreign people who obviously he will be very much afraid. So try to understand that whether he's in a hyperactive delirium. Now, once you know he's not in alcohol withdrawal, all this spontaneous breathing is okay, there are no ancillary drugs going on, and then he has gone in a hyperactive delirium, then probably to calm down, you may use, say, haloperidol, you may use a quetiapine, you may use say, low dose benzodiazepine. So all these things, or say propofol also, to just for a short period of time to take care of that hyperactive delirium.
But finally, you have to identify the costs.
Yes, it is very, yes. It is absolutely important why you are dealing. Hence, also we need to understand that whether this man was like this before, whether he's a dementic person. So the historically also we need to know. So all these things are very important before you label somebody hyperactive delirium and use the pharmacology.
Yeah. Another interesting question is, in a neurotrauma patients, can we go for this SAT and SPT?
Yes. That is, in fact, neurotrauma patients are the patient who need to be given SAT and SPT as early as possible, because remember, you are intubating and ventilating the neurotrauma patient not because of his lungs, but because of his airway protective thing. So you need to get rid of that tube as early as possible, because you don't want to induce any additional lung problem when you already have a brain problem. So in fact, there is always a tussle between the neurosurgeon and an intensivist, that the intensivist wants to intubate the patient because the GC is less than 7, but the neurosurgeon or neurophysician will come, don't give, nothing will happen. He's got a spontaneous cough, his brainstem is good. So these are the patients who need to be least on the intubation ventilation. So unless there is a definite need, like the patient need to be sedated, paralyzed for his brain swelling, cerebral edema, these patients need to be as soon as possible given a spontaneous awakening trial and breathing trial. Suppose they are not able to awake, sometimes they will know. It may take some long. To take a help of the neurophysician, whether he is, the whole aim is to, is he able to protect his airway or not. If he is able to do that, then that needs to come out.
So especially in a neurotrauma patient, it is very, very essential that we are doing, even though patient is on sedation because of so much irritability, we have to stop sedation every day. So that is called a check. So you have to stop sedation for the frequent neurological assessment. So especially in a patient with neurotrauma, SAT and SPT is very, very essential.
Yep.
Okay. Any more questions?
Yeah, when we extubate patient after 1 day, why sometimes patient go in ICU psychosis? Is it due to the use of excessive sedation? Well, now that is a very good question. There is something like, for example, the person had been on, say, benzos for say 15 days or 20 days, and then you suddenly stop benzos. Obviously, you are going to have some kind of the withdrawal things, whether it's an opioid or whether other things are there, you are definitely going to have some kind of withdrawal thing. ICU psychosis, most of the time it is more of an hyperactive or agitation kind of thing. Talking to them, ensuring that it's not drug withdrawal, and giving a low dose of antipsychotics and reorienting them that they are in the ICU will definitely help them in calming down. So after extubation, this is what you will be able to see or treat it.
I think what you have mentioned, the non-pharmacologic intervention is very, very essential to cope, to tide over this problem, ICU psychosis. The reorientation is very, very important. So always try this non-pharmacological intervention first before giving any medication for ICU psychosis.
Yes, I agree to that. Hardeep Kaur is asking, sir, when and from where can we get access? I think this is academy.com is where all the lectures are uploaded, na?
Or you can you can contact the ISSCM office.
Yes.
So they can call they can drop a mail to education@isccm.org. I will send them the link for the YouTube where we are uploading them.
Do you treat similar way for the hypoactive too? Yes. In the hypoactive delirium, unfortunately, you don't have to sedate or use the sedations. You might sometimes just give them some time and take out the confounding factors. Most of the time, hypoactive gets bounces back very easy.
Yeah.
There are too many thank yous, but
any other questions?
Let's stick to the current one, guys. A, B, C, D, E. Start practicing.
Yeah, I think this is very, very important. Let me conclude. If there are no more questions. So, basic idea that the critical care nurse, that is a very important part of the ICU care, and at least they have to be little proactive. So by creating the environment like this, by making them aware about all these protocols, we are making them proactive. Then at least you also take part into the decision making process in the treatment of the patients. So this is very, very essential. So all these protocols, all this safety check, you have to do your own self. And whenever you have any confusion, any doubts, you can always ask your consultants about that. So it is basically a chain of improvements. So once when you be a part of that process, then overall care of the patients is definitely going to improve. So that is our attempt. So always understand all these basic protocols, uh, learn these basic bundles, and try to be proactive as far as your role is concerned in ICU.